Dr. Jonathan Dewey. Jonathan is with Servier Pharmaceuticals. He is the Senior Medical Director for Solid Tumors. He brings experience from previous roles at Servier, of course, Sonify, and IDH1. He is currently involved in the, I always say this wrong, so sorry, vorasidenib expanded access program, which we'll maybe learn a little bit more about. And he's going to talk to us today, which is such good information. What IDH1 and IDH2 markers are, and he's specifically going to be talking about IDH1 and IDH2 mutated gliomas. And this is exciting because this is a whole different area of potential treatment option based on markers. Jonathan, are you joining us?
Yes, I'm here, Deland. How are you?
I'm great. How are you?
Good. Good to see you again.
Nice to see you.
Thanks so much for the introduction. I don't know if Patrick is still on the call, but I wanted to say hello to my fellow Utahn, who I saw that on his jersey that he played hockey at University of Utah.
He was the goalie. He was the goalie.
Yes, I saw it. No, that's great. So as you can see from my background, actually, I live in northern Utah, even though I work for a Boston-based company. And I did my master's in biomedical informatics at University of Utah. So yeah, hello to Patrick. Congrats to him and the other National Hope Award nominees, and really congrats to all of the patients and their caregivers who are still fighting brain cancer. So thanks to you, and thanks for all that you do. I am going to start my presentation with some disclaimers. Of course, let me share my screen. So the disclaimer that I have to start with is just to say that this presentation is for educational purposes only. Servier does not have an approved medication for the treatment of glioma, and that only approved uses and products can be represented as safe and effective as defined by the approved product labeling. Now, the other thing I wanted to do, Deland, is to apologize for the nature of my slides. They were originally approved for the use of educating providers, and I noticed your thanks for the more patient-friendly slides. So I'm going to, first of all, do my best to focus everybody just on the parts of the slides that are most important, and then also make up for it by starting with an analogy to kind of illustrate why it's important to understand the biology of tumor cells and how we use that in developing treatments for cancer. And that analogy actually has to do with living in northern Utah as well. There are a lot of benefits to living in a more rural area, as you can see from my background. You have some natural beauty. But one of the disadvantages is that weeds grow very well where I live. And when I'm on the road for a while, as I have been recently, they can get out of control. And I was doing some long overdue yard work this week. And there are certain areas of my yard where I don't have anything of importance growing. And in those areas, I just have a lot of weeds. And I can use a weed killer that just kills all plants, and that's fine. But in my lawn, on the other hand, I have grass, which I very much want to keep, but I also have dandelions, unfortunately. And there I can use certain fertilizers or sprays that target only the dandelions that I don't want in my lawn, but that don't target the grass. And that's possible because somebody somewhere took the time to understand the molecular nature of dandelions and how it was different than grass, so that I could use a targeted therapy, if you will, for my lawn and target only the dandelions. And that's what understanding IDH mutations really does for us when it comes to developing treatment for brain cancers. The goal is to be able to identify ways that brain cancers are different from normal cells and target those differences so that we can prevent or slow the growth of the brain cancer without doing damage to normal cells in the body. So with that, I wanted to dive in and provide a little education on the IDH mutations specifically and how those help us understand brain cancer cells. IDH mutations were first discovered as being linked to glioma in 2008. And if I can take you back to high school biology, in this middle section, you'll see a bunch of A's and T's and G's and C's, and that represents the DNA of the tumor cell. And in certain locations in that DNA, there can be mutations in these genes, and those mutations lead to changes in an enzyme called isocitrate dehydrogenase. And there are different versions of that, IDH1 or IDH2. But those mutations and those differences lead to changes in the metabolism of the cell and lead it to behave in ways that are more like cancer. And importantly, even as early as this publication in 2008, as you can see on the far right, the researchers noticed that when they were looking at what was then classified as glioblastomas, the glioblastomas that had these IDH mutations tend to have a different prognosis than the glioblastomas that did not have the IDH mutations. The cancer cells with the mutations, or the patients that had tumors with the mutations, tended to have a longer survival time than the patients that did not have the mutations. Subsequent research helped scientists understand why that's the case. The cancer cells that have the mutated IDH genes lead to an overproduction of a molecule called 2-hydroxyglutarate. And that's a really long word, but what it essentially comes down to is that that overproduction of 2-hydroxyglutarate has an impact on the cancer cells that makes them more cancer-like. It can lead to unchecked growth of the cells. It can lead them to actually suppress the body's normal immune cells that would otherwise be able to detect and kill the abnormal cells. And in this way, the IDH mutations promote the development of the brain cancers. Now, in the last decade, the importance of the IDH mutations has been increasingly reflected in the guidelines that physicians use to classify disease and to determine the best treatment options for a particular patient. In 2007, before the IDH mutations were discovered and linked to glioma, the grading of gliomas was based mostly on the features of the tumor cell that a physician could see while looking under the microscope. But as of 2021, the molecular characteristics, like mutations or other genetic abnormalities, are recognized as a key factor in determining the grade of a glioma. And so now, if you look at the different grading or the different classifications for adult-type diffuse gliomas, you see that there are really only 3 different categories. And one of the most important factors in determining which category a tumor falls into is whether or not there is an IDH mutation. In fact, this is so important that if there is no IDH mutation in an adult-type diffuse glioma, it is now automatically classified as a glioblastoma grade 4 tumor with wild-type IDH. Wild-type means there's no mutation. Whereas if there is a mutation, then it's either an astrocytoma, or if there's a mutation and a different genetic abnormality, which is called a 1p19q codeletion, then it's an oligodendroglioma. And the prognosis of each of those cancer types is different. Each of them has a different trend in overall survival or even progression-free survival. And as these graphs show, the gliomas that have both an IDH mutation and a 1p19q codeletion have the best prognosis. Now, one thing that it's really important for physicians and patients to understand, and in fact, this is something that Dr. Hamp mentioned in his presentation earlier this morning, is that while these tumors can often be treated pretty effectively with surgical resection, the tumors are diffuse, and as he described really well, there are these microscopic parts of the tumor that you actually can't even see on MRI with the magnification, but they're still there. And so it's really important for patients and providers to understand that even if you have what's called a gross total resection, that there are still cancer cells there. The other thing that's really important for patients and physicians to understand is that those cancer cells are there and they're always growing. The growth is pretty continuous in these tumors, regardless of how much of the tumor was removed surgically. But what does affect the rate of growth is actually the molecular makeup of the cells. So there are certain molecular changes in a cell that will lead it to grow more quickly versus more slowly. And those are some of the factors that are now coming into play with the tumor classification and determine whether it's grade 2, grade 3, or grade 4. And that's even within an IDH mutated tumor. There are other changes that can lead an IDH mutated tumor to grow either more slowly or more quickly. So the last thing that I want to communicate, and this just goes back to kind of that analogy of whether you can treat something like my lawn with a targeted therapy or not. And the way that you can do that is by understanding what's going on molecularly with the cell. And so I won't go into all of the details here, but I'll just say that there are a variety of molecular pathways within IDH mutated tumors that provide an opportunity for us to attack this tumor cell without or with minimizing the negative impact on normal cells. And IDH mutations are one of those key changes. So in summary, IDH mutations are really important in the development of some gliomas, and the presence of the mutation has a really important implication for disease prognosis. These mutations can often, or they do, affect the treatment choices that a physician will make. These tumors can often be removed, at least in part, by surgical resection, but the cancer is always there and will continue to grow over time. And understanding whether or not a brain tumor has an IDH mutation is really critical to understanding the prognosis and the best treatment options for that patient. And importantly, and the reason why this matters so much to patients, to their families, to physicians, is that hopefully with this knowledge, we can develop ways to target tumors in a way that allows us to spare the normal function of the brain while effectively slowing the growth of the tumors. And with that, happy to answer any questions.
Thank you, Dr. Dewey. That is really great. Thanks for okay, so sometimes people, patients, caregivers, family members get frustrated, right? About the lack of evolvement in the treatment of gliomas, low grade and high grade. So what you talked about today is definitely a step in the right direction as far as how these tumors can be treated in the future. So for me, as a patient advocate, that it just excites me so much, right? Because the treatment for gliomas is evolving, and I feel like there's much to be hopeful for. And the importance of the IDH1, IDH2 markers, really are a game changer. And now that we're starting to look at those and the guidelines have changed, you know, I can certainly see patients being diagnosed with gliomas today feeling more hopeful than ever, truthfully.
Yeah, even without a therapy that specifically targets that mutation, just understanding the difference in prognosis with these tumors based on the mutation has already led to changes in guidelines as to how aggressive a physician will be with chemotherapy, with radiotherapy, with surgery. And so that understanding of the biology is already changing the treatment landscape.
Which is so exciting.
It is.
Yeah, I mean, you know, we always ask for that. There is a question in the chat box, and we'll answer that question, and then we do need to move on. Do you see that, or can I read that to you?
I do see it. It says, what is the difference between Tibsovo and vorasidenib? My daughter is currently taking Tibsovo via compassionate use when the clinical trial closed before she was able to join it. I will say, so first of all, because Servier does not have an approved drug for glioma, right? I can't say anything about safety and efficacy of the drugs, but because the question is specifically about the difference of the two drugs, I can say that they are both designed to target IDH mutations. Tibsovo is specifically targets IDH1 mutations, and vorasidenib targets both IDH1 and IDH2 mutations.
Very cool. Thank you. Thank you. Any other quick questions before we move on? I want to thank Dr. Dewey for your time today. You're right. That picture behind you is really pretty. Did you do you ski?
I do ski, yes, and I've taught my kids, and we love it.
My son was there a couple of months ago skiing, and it was the best skiing he's ever experienced.
That's great. I'm glad to hear it.
Fantastic.
Thanks for having me here.
Thank you so much. Dr. Dewey's contact information is right there on your screen. Please don't hesitate to reach out to him if you have more questions related to IDH1 and IDH2. Thank you so much for your presentation. That was fabulous.
You're welcome. It was a pleasure to be here. Thank you.
Thank you.